Welcome to Venous Lymphatic University. My name is Lowell Kabnick, and I'm pleased to have three vascular medicine specialists today. The lead speaker will be Raghu Kolluri, followed by discussants Omar Esponda and Stephen Dean. So let's take it away and start.
Thank you, Lowell. Can I share my screen now?
Please.
All right. Thank you for this invite. Appreciate it. Let's see. Okay. Yeah, and everyone is able to see my screen, right?
Yes.
Okay. So the topic assigned to me by Lowell is differentiating venous ulcers from other pathology, and this eventually ended up being a core curriculum paper in the Vascular Medicine Journal. One of my co-authors and friend, Dr. Stephen Dean, is also on this call. I'm eager to hear his perspective. It was a long time making for this manuscript to be published, but we'll talk about that. These are my disclosures, nothing pertinent to today's talk. This is the paper I was talking about. I'll put this QR code just in case, for a few slides here and there, in case you want to download it. It's free to download from the Vascular Medicine Journal. Again, it was almost 10 or 15 years in the making to collect all these ulcers over time. Just wanted to start with a couple of cases of how routinely we see these things. This was a few years ago. I was consulted in the hospital to see a patient who came in with this extremely painful ulceration literally 2 months after a GSV and SSV staged ablation sent elsewhere. And as you can see, it's kind of circumferential, black area. He swore that his testing revealed that the circulation was okay, other than the vein valve problems. And then he ended up with this. And you can start seeing some rash on the thigh there. And when I look at it on the other side, there's some rash on that side too. This was purpura, and it was non-blanching. So I couldn't feel a pulse. Turned out that he actually had critical limb ischemia, arterial disease too, with ABI of 0.04 on the right side and 0.52 on the left side. And again, as I said, he swore that a few months ago the circulatory test was fine, which was weird. But anyway, his SFA was occluded, as you can see, but the occlusion, as you can see, is organized thrombus more than, plaque buildup. Yes, there is plaque, but, it sort of is, there's something else going on there too. Screening lab tests, BMP, some minor abnormalities, but you can see CBC shows anemia with a crit of 22.8. Platelets are down. So something not right in this whole picture here. He was revascularized quickly. The SFA was recanalized and stented. He was sent to the operating room for OR debridement because it was a very thick eschar and he was in severe pain. After revascularization while in the hospital, he was sent to the OR for debridement with plastics. But he on exam he also had hepatomegaly. His history was kind of somewhat goofy. He was an alcoholic at one point, but he's recovering and all that stuff. So I went ahead and ordered hepatitis panel, and lo and behold, with the rash and the history, the hepatomegaly, he was noted to have Hep C positive tests. Then I went on to order complement levels and cryoglobulin levels because Hep C is associated with cryoglobulinemia, which is associated with ulcers and the rash that we looked at and all that. And lo and behold, The total complement level was low, the C4 was low, C3 was normal, and the cryoprecipitate was positive, but the viscosity was normal. So this was basically beginning to look like immune complex mediated cryoglobulinemia. So sent it off for immunofixation, and it was monoclonal IgM, confirming the diagnosis of type 2 mixed cryoglobulinemia. Um, he ended up getting a CT scan, and there's a B-cell lymphoma in there, which is proliferating, most likely causing all of these things. So he was oncology was consulted immediately, ID was consulted, rituximab was started, IV salumeterol was started, and then Hep C treatment was planned later on in 3 months. So that just shows what might present like an ulcer turns out to be so many different things. Here's another example. After GSV ablation, I first saw her in 2024, ended up having, again, similar rash, and then, also had this distal toe ischemia. Full workup, included basically just a small arch atheroma, which I did not believe was causing all of these things. Had patent foraminovaly, but that was very small. The structural folks did not think that that caused anything much. She also has type 2 diabetes, hypertension, and dyslipidemia. So I did a CTA. Nothing much showed other than that small atheroma of 3 millimeters. Clinically relevant alternative etiologies were ruled out. There was a small PFO, but no right to left shunt. It was a TEE that we did. Again, cryoglobulins were mildly elevated, but ANA was positive. And then I referred to one of my, favorite hematologists, very academic. And he said, "Nah, this is not cryoglobulinemia. Immunofixation all came back negative." So I started treating this lady with arterial embolic events with apixaban, diltiazem for vasodilation, aspirin. Then she went and saw a second opinion, my friend Jay at Cleveland Clinic, and Jay basically told the patient that Raghu knows what he's doing. I might suggest Pleatol, but being on Jay's my vascular medicine colleague at Cleveland Clinic. So Jay Bishop, apixaban, diltiazem, aspirin, then throwing Pleatol. I don't know if it was going to do much, but anyway, I did not do that. I did put her in statin, but here is the timeline. So I tested when I saw her in 2024, the antiphospholipid antibody workup was negative. She had that blue toe, had the venous ulcer that was treated. Then she was referred by someone to Ohio State dermatology, Dr. Stephen Deanland. They found a mild elevation in the IgM of the anticardiolipins. And meanwhile, the hematologist did not think that that was much. I did not think that that was enough to call it APLA. But then she ended up having another necrotic event, and she basically necrosed her toe and needed an amputation while on apixaban. Then repeat again, antiphospholipid workup showed mild elevation in anticardiolipins. So at this time, the hematologist spoke with me, and we both decided, you know what, let's put her on warfarin and see what happens. Stop the Eliquis. She has remained stable. No events. Otherwise, she was just getting these ischemic events, but it all started with a venous ulcer. So again, these two just basically show how it may present as venous ulcer, but it could be a lot, many different things. So this is the paper. We all know that venous ulcers are formed because of venous hypertension, the microangiopathy, the inflammation, and the hypertension is either structural or functional. We talked about this with Ari Fukaya in our paper. Whatever it is, it ultimately will result in venous ulceration, and that presentation could be a typical VLU or an atypical VLU, but then there could be mimics that are either vascular or non-vascular. That's how we wanted to sort of differentiate these vast list of ulcers that we collected between Dr. Dean, me, and Dr. Fukaya. So again, as I said, typical VLU, atypical VLU, non-venous vascular ulcers, and non-vascular ulcers. So how do we go through this? Well, first off, we need to understand typical and atypical VLUs, right? Typical, we all know, painless gator area ulcers, but then there are atrophy blanche ulcers, which can present either with or without livedoid vasculopathy. Figure D is one of Dr. Dean and my common patient, with livedoid vasculopathy leading to atrophy blanche ulcers, who's on the maintenance sclerotherapy where they keep coming, and then we do subulcer sclerotherapy. You see a dorsum of the foot ulcer there, which is also atrophy blanche, but the characteristic sort of fern-shaped shallow ulcers in a marble textured area is atrophy blanche ulcers. Sometimes these patients need anticoagulation if they're not healing. I use it. I know that Dr. Dean uses anticoagulation if they don't heal. They can also present with venous eczema, which could be pretty severe, as you can see here. Pretty dried out venous eczema, but then it can also spread to the rest of the body, called the autosensitization or id reaction, with diffuse itching and diffuse rash. If that cycle continues, then it becomes the keloids too. As you can see, this person has over years scratched and resulted in keloids all over. The other presentation is heterotopic ossificans because of the ossification of the subcutaneous tissue. You can see on the X-ray multiple stones. This is courtesy Josh Beckman, where you can actually see these stones extrude out of these venous ulcers. Then there are other different types, mixed, meaning, you could have phlebolymphedema leading to ENV, which is elephantiasis nostrus verrucosa, where you have these verrucous changes, but they just end up resulting in these profound ulcers. Then you have arterial ulcers, and mixed with venous, you have ischemia, that is the panel B. And then C here is acroangiodermatitis of Malley, which is basically angio proliferation and microscopic extravasation of RBCs, the pseudocaposi-sarcoma. Then non-venous ulcers, these are hypertensive ulcers, Martorell's ulcer, which generally comes in as a potential small saphenous vein ablation because of the location. APLA, this is the example of APLA. They were right there. It was referred to me as a venous ulcer. It's not. Those with erythromelalgia soak their feet so much in in cold water that they can have maceration-related ulcerations too. Then Henoch-Schönlein purpura, all these other autoimmune manifestations, erythema nodosum, as you can see, that can ulcerate. The more common one is the pyoderma gangrenosum. We can talk about it during discussion. And then we talked about cryoglobulinemia. Now, different types of skin cancers should be kept in mind, whether it's cutaneous, squamous cell, or basal cell, or T-cell lymphoma. One is lymphangiosarcoma. And all these bleed briskly. They're fungating, hypergranulated. The last one is Kaposi through from HIV that are nodular, then ulcerate as well. Then they're infectious, for example, here, osteomyelitis, where the screw is coming loose, and then there is an ulcer referred to as venous ulcer. This is basically cat scratch fever, infectious. And here is a hematoma with a scimitar sign where it spares the hematoma spares the malleolus itself and tracks behind it. And then you have the pressure ulceration directly over the malleolus as opposed to the gator area. And as you can see, that patient has been compressed for venous ulcer. with Una boots. You see the compression on it. That's not the treatment for it. Then there are chemical induced like brown recluse spider. This is the tattoo related. And then cannot forget squamous cell carcinoma. I'm sorry, sickle cell anemia that can cause it too. And then some psychiatric things where this is chronic itch scratch cycle, NLD, which has the candle flame-like appearance in diabetics, the calciphylaxis, and warfarin skin necrosis. It's a lot to cover, Lowell. Sorry, I went over because there's so many of these. But my recommendation is to just consider that there might be other things. Go with the horses first, zebras, and then spotted zebras, and onward to the unicorns in terms of the differential diagnosis. Sorry. Thank you.
Thank you very much, Raghu. That was unbelievable. I've got to
Thank
study
you.
now. I mean, it's it's amazing. But in reality, to framework it, as you said, if you hear hoofbeats, you're looking for horses and venous ulcers, especially if it comes to you. And I mean, this is a collection of many patients and also a lot of vascular medicine physicians, as well as other physicians, and to put it in framework. So I'm going to turn it over to Steve Dean for comment or question.
Common question. Well, yeah, like there's a lot to cover this. I can't comment on all of them, but the one I do find just fascinating is the atrophy blanche, and that's really important to the venous world because when you think of atrophy blanche, ulcerations or scarring, you really are looking two categories. You either have livedoid vasculopathy associated atrophy blanche, or you have venous stasis ulcers or venous limb ulcers or CVI associated atrophy blanche. So it's a dichotomy between those two, and they present entirely different. Raghu showed a good picture, and he pointed out the fact that there were ulcers on the dorsum of the foot. So, I mean, that's not your typical area for venous limb ulcer, obviously. It can occur there, but it's not typical. So that right there would be something to consider if you see, and not only that, the pain is exquisite in a livedoid vasculopathy associated ulceration. And then also, hence the name, the livedoid usually connotes that they have associated livido-racemosa, or at least some purplish modeling within that extremity as well. You shouldn't see that with the venous limb ulcer or venous stasis. So that helps you distinguish between the two because the treatment's entirely different. Because like Raghu said, if you have livedoid vasculopathy associated with blanche, those patients need to be anticoagulated because otherwise they're really, really hard to heal. And then obviously CVI, it's a whole different issue, which you're more than aware of. Now, where it really gets interesting is about 10% of these patients have atrophy blanche from both of these disorders. They can actually occur concurrently, and then
Yeah.
it's a real nightmare. And Raghu and I actually shared one of these patients in the past, and even though we'd done all the right things from an anticoagulation standpoint, antiplatelet therapy, he didn't heal until Raghu actually worked his magic and used foam sclerotherapy on him. But he was clearly a hybrid of both of these. So to me, of all these things, I find that the most fascinating, the livedoid vasculopathy versus venous limb or venous stasis, excuse me, atrophy blanche.
Steve, fantastic point. And the two pictures here also show the satellite lesions, the with the livedoid, which have multiple healed ulcers too. This is that patient you're referring to that had both. The panel D.
Okay. Yeah, I
Yep.
haven't seen that guy for a while. Yeah.
Yeah.
Thank you very much. This is really informative, but it's an isolated case, and as a vascular surgeon, I hope never to see this. But if I do, I will now recognize it. Omar, your comments.
So, excellent presentation. It's understandable how it had years in the making, right? You'll need a very fruitful career to actually see all of these cases yourself. But hear me out. Like in an era where Doppler ultrasound is easily available and it's easy to diagnose venous reflux and then just blame it on reflux on the ulcer. I mean, how do you avoid anchoring bias when venous is present, but it may not be actually the primary driver for the wound?
So Omar, that's a great question. And you saw the two example cases where things happened after the endovenous ablation. So I'm not saying that we should not take care of the refluxing vein. For example, that tattoo ulcer that you saw, that was, the irritation to the yellow of the yellow color of the tattoo. But guess how it healed? There was also associated small saphenous vein reflux that I treated, and it healed magically after that with one appligraph. So it's a combination of things, right? Yes, we all have anchoring bias, but the thing is, the most important thing, in my opinion, is to have that longitudinal follow-up and not say, bye-bye, we're done with, your venous ulcer. So because you have to follow them up, and then if they start acting up different ways, then, as I said, I mean, yes, there are horses, but we got to think that maybe there is an alternate diagnosis, especially looking at these other associations, right? I mean, my patient had a hepatomegaly, right? I mean, that was the trigger for going through the whole thing. It's a good physical examination and history.
Yeah, so yeah, I'll dovetail on that as far as the physical examination, especially, we all know what the manifestations are of chronic venous insufficiency, but if any of those limbs you encountered livedo reticularis or livedo racemosa, or
Right.
you saw the petechiae like Raghu said or saw, those are things that would trigger you right away. There's something else going on, that it's not
Yeah.
consistent with typical venous stasis, just as.
Well, I'm going to jump in here. KJ, thank you for joining us as a vascular surgeon here. The first case that you presented, Raghu, I had some questions about it in terms of what procedure went first. And KJ, what did you think about that first case and the vascular surgeon jumping in on that case?
I think it was a premature thing, without actually understand. Can you hear me?
Yes, now.
Better.
Okay, good. Sorry about that. I think that, as a surgeon, you kind of have this mentality that, steel is what heals. But in reality, I think they should have probably taken a pause and examined it a little bit more before cutting into it, especially when you're dealing with a wound that you're not really confident you know what's going on. Before you cut, it's probably best to get some more opinions on what's going on.
Well, thank you. Any other comments, questions?
So one more.
Clarification, cut into is what, the biopsy you mean? Or the debridement?
Yeah, the debridement.
The debridement was after second day after revascularization. And we thought that would give us the biopsy too. So it was a decision between vascular surgery, vascular medicine, and plastic surgery.
But the eschar did not appear to be in a relationship to arterial. And so
Right.
that's what kind of made me ask the question. And furthermore, as you said, this is complementary in combination of disease processes, and which one really takes precedence. And so I think the underlying diagnosis would have been established first.
Yeah, the patient was in the hospital for, I think, 3 full weeks. So, yeah, a lot happened.
The question I have, though, is if the wound is not in a typical arterial distribution and they've had a revascularization, debriding it after the revascularization may not leave you with benefit, right? I mean, because it's not a typical arterial presentation of a wound. And so you revascularize it, that's great, but debriding it may just leave you with a bigger hole.
Anyway, Omar?
Well, the only other thing is,
KJ.
in your experience, Raghu, which ulcer mimics lead to the greatest delays in appropriate treatment of all the ulcers that you've seen?
I think there's a lot more understanding of pyoderma gangrenosum over the last decade, so that generally is the first thing people jump on. But the more important thing I feel is more than the delays, things that can potentially cause devastating consequences, such as antiphospholipid antibody syndrome, the cryoglobulinemia, where there's an underlying cancer, those type of things. I think that, in my opinion, is more important than the, other things that can be handled where the patient is not going to have a stroke or die from it.
Great,
Yeah,
thank
Raghu,
you.
I like that comment on pyoderma. I was going to say, I think that is often overlooked and misdiagnosed as venous limb ulcer because it's occurring in an elderly population. They have venous stasis hyperpigmentation. They biopsy the patient. It comes back inflammation and venous stasis. So therefore, it is venous stasis ulcer. But it's a painful ulcer that's refractory to compression and typical management, and that's right there with the periulcerative halo and a heaped up rolled border. But I was going to say I've seen a couple of those cases, and everybody was hanging on the biopsy showing stasis. Well, the patient had background stasis, but it wasn't causing that painful refractory ulceration. Just angry, inflammatory looking with a fibropurulent base. It's just not consistent with PG. So I can think of 3 of those off the top of my head that I've seen.
Yeah, I mean, we've been using the Paracelsus score quite a bit, for the clinical diagnosis of pyoderma, Steve, which works great.
This has been absolutely amazing. And Neil Hingorani, my partner at Venous Lymphatic University, actually commented on your paper in the chat box. And I suggest that everybody read that paper, especially if you're involved in venous or arterial disease and you're not in the vascular medicine type of group. So thank you, Dr. Kolluri. That was amazing. And for
Thanks.
me, I learned
Yeah,
a
that's
whole
great.
lot.
Good.
Thank you, Steve, as well, and Omar and
Thanks,
KJ for
everybody.
your comments. Next week, very interesting, we're going to talk about the Fortegra venous stent and what do we know and what's the data. So I look forward to Dr. Stephen Abramowitz and Kush Desai. So we'll see some of you next week. Thank you very much and have a great rest of your day.
Thanks, Lowell.
Bye.
Thanks for
Thank you.
having me.
Bye.
See you all. Bye-bye.